So the topic of the lecture today is hypertensive heart diseases. First of all, we have to know what hypertension is. When we measure the blood pressure, it's in systole and diastole. So whenever we go for a normal blood pressure, it must be 120 by 80, 120 systolic and 80 diastolic. So when do we say it's hypertension? When do we say it's higher blood pressure? Whenever the systolic blood pressure is more than 140 or 140 and diastolic pressure is more than 90 or 90, it's high blood pressure. It's higher blood pressure. But when do we label a person hypertensive? We label a person hypertensive whenever we know that that person has a sustained blood pressure, sustained systolic blood pressure of more than 140 or 140, or if a person has sustained blood pressure or sustained blood pressure of 90 in diastolic or more than 90 for a long time, we label that person hypertensive. In most of the cases, both of these things occur together. A patient will have a sustained blood pressure of more than 140 by 90 or 140 by 90. So we label the person hypertensive whenever that person gets above or equal to 140 by 90. It can be either one of those parameters. It can be either 140 or it can either be 90. So what are hypertensive heart diseases? What heart diseases lead to hypertension, or how hypertension leads to some of the major heart diseases? Let's get on with it. First of all, we know the term hypertension. Hypertension meaning a sustained blood pressure of 140 or a sustained blood pressure of 90 or a sustained blood pressure of 140 by 90 or above. We label that person or condition as hypertension, or that person hypertensive. So first of all, this is the normal heart, and look at it. As you can see, these are the red blood cells and they're roaming around in that vessel, roaming around in the lumen of the vessel, and there's that plaque, there's that atherosclerotic plaque that is being formed. Some of it are going to even adhere to it. So look at the lumen size. The lumen was too wide, and at this point the lumen has become narrow. This is one of the basic reasons of developing hypertension. So lumen of this place has become narrower. So hypertensive heart diseases, it can be increased blood pressure, left ventricular hypertrophy, and ventricular dilation and failure. Now these are the consequences of hypertensive heart diseases. Now let's understand them. We got to know these three steps. Now let's understand them. For example, a patient has developed an atherosclerotic plaque. What will happen? This narrow lumen present here, there will be more pressure required to push the blood through that. Otherwise, it will be pooling of blood. So the heart will pump harder and harder and harder. So the blood pressure, the pressure with which the blood should come out, will be increased. And one way or another, it will lead to left ventricular hypertrophy, because ventricles are already thick. Left ventricle is already thick. Why is it thick? Because it has to sustain a blood pressure of 120 by 80, and it has to ejaculate the blood. It has to push the blood at higher pressure so that it may reach every single cell inside the body. So left ventricle has a major function to do. So what will happen if any of it goes wrong? If there's any blockage, if there's any thrombosis, if there's any atherosclerosis, or there are other multiple factors, it can also be because of predisposition, genetic predisposition. So whatever the reason is, if left ventricle was pushing at its maximum, now it has to even increase its maximum to get to that pressure which will saturate our body with the blood and oxygen demand. So the left ventricle will contract more vigorously now. When it will contract more vigorously, what will happen? Left ventricle will dilate. Left ventricle will dilate to increase its pressure, to increase its power. So it will, one way or another, up to some point it will be physiological. Because we see athletes running around all day, they have left ventricular hypertrophy. But up to some limit, it's physiological. But after that limit, it's pathological. After that limit, the nucleus goes away. Nucleus moves away. And when the nucleus moves away, it's very difficult for even heart to supply the blood to its own cells. And that will lead to ventricular dilation, not hypertrophy. Now it will dilate. You can see this was the normal way, but now it has dilated. When dilation happens, for example, there's a pump. You have this hand. Now it's pumping. When we dilate the hand and we have to pump, we cannot pump that vigorously. We cannot pump that efficiently. So left ventricular hypertrophy happened. That led to ventricular dilation. Now after ventricular dilation, ventricles are not doing their function at the maximum at the maximum of their capacity, because they're not able to work as a pump. They have been dilated, they have been hypertrophied. Now they cannot come together as a unit and go away as a unit. So one way or another it will lead to ventricular failure. And what is ventricular failure? When ventricles are unable to meet the oxygen demand of the body, they are failed. And they will continuously do so because they are hypertrophied, they are dilated, they cannot do their function at its maximum. So that's how a hypertensive heart disease leads to ventricular failure and in turn leads to cardiac failure. And what are the consequences of it? We're going to learn about that in the next slides. Next on, we have hypertensive heart disease to heart failure. First of all, we have to know the degrees of it. What's the degree of hypertension? Or what's the degree of heart failure? So, first of all, degree 1. In the first degree, left diastolic dysfunction and no left ventricular hypertrophy. So, in the first degree of heart failure, left ventricular hypertrophy is not happening. It's yet in the very early stages. Patient is developing this disease, but what's failing here is left diastolic function. It's not pulling the blood back in. What happens at ventricular diastole? The blood fills in. So it's not doing its proper function. Left ventricle is still not hypertrophy. Left ventricle is still there, intact, working its pumping activity at its maximum. No hypertrophy there, but left ventricular diastole is affected. Now this is first degree. What will happen in the second degree? It will get worse. In this, left ventricular dysfunction and left ventricular hypertrophy. Now left ventricular dysfunction is still there. It's not getting enough blood. It's not pulling blood. It's not accumulating blood. And now left ventricles are hypertrophy. Now the blood pressure is rising. Now the blood pressure is rising dramatically. When the blood pressure will rise dramatically, left ventricle will have to push the blood with more pressure, with more force. When there's more pressure and there's more force, what will happen? Hypertrophy of the ventricles will happen. When the ventricles are hypertrophied, we learned in the last slide what are the consequences of it afterwards. We're going to see them in the slide too. So clinical heart failure with presented LV ejaculation fraction. EF, it's called EF. Some people call it ejection fraction, some people call it ejaculation fraction. I hope that you understand this term. Go by EF, ejection fraction or ejaculation fraction, whatever suits you. So in this clinical heart failure with presented LV ejaculation fraction, now the heart is failing because it has hypertrophied, it has dilated in size, now it's failing, but it's clinical heart failure. We're getting clinical symptoms. Patient is having clinical heart failure, not physiological heart failure. So, what do you mean by clinical heart failure? Clinical heart failure means it's not providing the whole body with enough oxygen and blood. Many of the extremities, many of the distal organs, many of the distal structures are becoming cyanosed. For example, your lips, your nails, your toes. They're not perfectly perfused. So they are hyperperfused, and that's why it's called clinical heart failure. Now at the fourth stage, we all know this clinical heart failure will one way or another lead to a proper heart failure. And in degree 4, eccentric LV hypertrophy, reduced LV ejection fraction. Now it has hypertrophied up to that level that it cannot even pump properly to push the blood out. Whenever it does this, it pumps the blood out. Whenever it does this, it's diastole. It's filling the blood from the upside. The blood is filling from the atrium into this ventricle. Now, due to immense hypertrophy, it cannot work as a pump. It will come maximum up till this. It will push very minute amount out of it. And that's why reduced left ventricular ejection fraction, and eccentric IV hypertrophy. You can see there are two types of hypertrophies: concentric, eccentric. Concentric means equal kind of hypertrophy in all the compartments. On the other hand, eccentric means if basically one area of the lung of the heart is hypertrophied too much, others are also hypertrophied. You can see major portions are hypertrophied, but left ventricle is basically into eccentric hypertrophy, and it will lead to cardiac failure one way or another. So you have to learn these four stages. What were these four stages? First, diastolic dysfunction, no left ventricular hypertrophy. Second, okay, both are there. Left ventricular diastolic dysfunction and along with it, left ventricular hypertrophy. Number three, clinical heart failure is there and left ventricle is going into hypertrophy. Number four, eccentric left ventricular hypertrophy and reduced ejection fraction. When there's reduced ejection fraction, what will happen? The heart won't be able to meet the demands of the body, won't be able to meet the needs of the oxygen of the body. So that's how the heart will fail. So this is how a hypertensive heart disease leads to heart failure, step by step, leading to this level. Next on we have systemic hypertensive heart disease. First of all, let's talk about left-sided. Decreased distance between valves, decreased ventricular space, increased cardiac muscle. Now this is systemic hypertensive heart disease of left side. We're going to talk about right side afterwards. Left side. So in systemic hypertensive heart disease, what three changes are we looking at? We're looking at decreased distance between valves. So what are the consequences of decreased distance between valves? For example, I have a valve who's this wide, so more and more blood will be passing through. If I reduce the size up to this level, now less blood will be going through, but more pressure will be required to push the blood out of this hole, out of this space, out of this distance between them walls. So if the distance between these valves are reduced, it means more and more pressure is required for atrium to push the blood into the ventricles. So this is how the blood pressure will increase. This is how the systemic hypertensive heart disease will propagate. So first reason. Second, decreased ventricular space. Now if ventricles are supposed to collect all the blood, they're supposed to have all the blood which is to go to all the body. So our ventricles are supposed to have a certain amount of blood in them. That's requirement for the body, and 60% out of that blood goes out in ejection fraction, meets the demands of the body, gets to every cell, gets to every tissue, gets to every organ, saturate them with oxygen and nutrient demands, and it goes on and on. So what happens if the space is reduced? If before, for example, not surely, for example, for 100 ml, now the space has reduced up to that level that it can contain only 80 ml. And if ejection fraction is still 80%, still 60%, how much blood will go out? 50. Before that it was 60. Now how a 50 ml will saturate the body needs when 60 ml was basically required? So what will happen? More and more left ventricular hypertrophy and more left ventricular force will be produced to eject more blood out of it, to eject more proportion of blood out of it, so that it can be 60. So it can be exactly those amounts or that amount which is required for the body. So now the left ventricles are going to contract like this to push all the blood out. So left ventricle will need more and more pressure, and that will lead to systemic hypertension. Third, increased cardiac muscle. Now cardiac muscle has increased. It's going to pump the blood out of it very vigorously. And that's also one reason of getting to the systemic hypertensive disease. Now this is a left-sided area in which all these muscles were supposed to supply the body with oxygen and blood. But what will happen on the right side? Right side is the same, but it has to push the blood into the pulmonary vasculature. So the pulmonary vasculature requires far less pressure for the blood to come and get oxygenated. Next, now we have systemic hypertensive heart disease, pathogenesis of it. Now we learned about all of these factors that get affected, and afterwards, those are the factors that get affected, and in turn, they affect the whole disease. They enhance the whole disease. It's like a cycle. Due to systemic hypertensive disease, valve distance decreased, it's also going to increase the systemic hypertension. Due to it, left ventricular space decreased, it's going to increase systemic hypertension. Muscle increased, increased hypertension. So they also in turn increase the systemic hypertension. Now we're going to learn the pathogenesis of it, that how a systemic hypertensive heart disease is actually produced or happens. So chronic left ventricular hypertrophy, arterial hypertrophy, and decreased aortic elastance. What do you mean by elastance? Aortic elastance means that aorta is not elastic at all. Decreased aortic elastance means it's not up to that point that it can increase or decrease and show its elastic power to sustain the blood pressure. When that elastance is gone and arterial hypertrophy is happening and chronic left ventricular hypertrophy is happening, what's going to go? Altered VV coupling will go on. So what is VV coupling? Ventricular vesicular coupling of ventricle. That's what it's called, VV coupling, ventricular vesicular coupling of the ventricle. So it will go altered. Next on, we'll have acute inflammation, sympathetic nervous system will come on, and hormonal effects will go on. So all of it will lead to vasoconstriction. We all know that during the acute inflammation or attack or any kind of infection, sympathetic nervous system comes in and it causes vasoconstriction, and hormonal effects will contribute to it, and all of these factors will lead to vasoconstriction. When vasoconstriction has happened, what's going to happen? It can be arterial, it can be venous, but mostly vasoconstriction is arterial. So due to arterial vasoconstriction, what's going to happen? Increased PWV. What is increased PWV? Pulse wave velocity. Increased pulse wave velocity means that the vessels are now more stiff. They're not elastic, they're more stiff. When they're more stiff, what are the consequences? Increased reflection or reflected pressure wave. When they're not stiff anymore, when the stiffiness is gone, now the pulse waves are going to be reflected and they're going to be higher. Because before that, if blood pressure was increased or decreased, what was going to happen? It was going to elongate, it was going to grow in size, it was elastic in nature, so it can adjust to that blood pressure. But once that stiffness has come in and that elasticity has gone down, the PWV came in, pulse wave velocity, and then reflected pressure waves are going to be more and more in order for it to get that effect of hypertension. Next on, we have increased afterload. Now, what is increased afterload? Afterload is the amount of work heart has to put in. That's the first definition that should come to your mind. Increased amount of work that heart has to put in. And in the heart, which structure? Left ventricle has to put in. So the amount of work left ventricle has to put in to eject the blood out of the left ventricle, that's called afterload. You can call it resistance too. Afterload may increase, afterload may decrease. Afterload is actually, you can call it a reading of resistance. For example, in a normal person, it's 120. So the heart has to get up to the level of 120 and eject the blood. Whenever it surpasses that afterload, it ejects the blood. Now the afterload is increased. Now the pressure, the resistance inside the vessels which are getting the blood supply from the left ventricle has increased dramatically. When it has increased, it needs more vigorous blood coming out of left ventricle. So more and more pressure will be required. and this will lead to left ventricular hypertrophy, and that will lead to left ventricular failure, because now the heart has to push with a larger force. So due to increased afterload, now as the heart is pumping at more power speed, at more speed and more power, what's going to happen? Its myocardial oxygen demand will go up. When myocardial oxygen demand will go up, what's going to happen? When myocardial oxygen demand goes up, heart will try to compensate. Heart will try to compensate. We learned about that if the oxygen demand is going up, what's going to happen to the coronary arteries? Coronary arteries will dilate. Coronary arteries first will dilate and try to provide the heart with its proper supply so that it can contract and relax, the cycle can go on. But what if there's some kind of thrombosis there, or atherosclerosis there, or vasospasm there? We talked about the collaterals will develop in that case. So heart will try to compensate its own needs by developing collaterals, by developing different mechanisms to support its own structure and integrity. But in some cases, it cannot do that. So it will also lead to ischemia. So this will lead to end organ ischemia. Now this end organ ischemia can be of heart. It can be of other organs too. Which other organs get affected by this kind of end organ ischemia? It can be brain, it can be kidney, it can be heart. Now how it can be heart? If coronary vessels don't support that much, if coronary vessels develop collaterals, but those collaterals are not good enough, those collaterals are not up to that mark to supply the heart with its supply. So you can easily get the gist of it, that if that's happening, if that's what is happening, heart won't be supplied with enough oxygen, with enough blood. And if heart is not supplied, those cells, those myocardial cells are going to die. And when those myocardial cells are going to die, what are the consequences? Now that part of the heart is not working. Now that part of the heart is not functioning. If it's not functioning, pumping activity is affected. Major part of the heart is not working. So this will lead to ischemia of other organs, because now the left ventricular ejection fraction is not up to the mark to get the whole body saturated with blood and oxygen. What will happen to kidneys? When kidneys are affected, when kidneys are hyperperfused, it affects the renin-angiotensin system. And if they are hyperperfused for a long time, they go into kidney failure. Brain, when brain is hyperperfused, what's going to happen? Brain, when hyperperfused, brain will start its own mechanism. Brain will start its own mechanism. First of all, the first symptoms that you get of hyperperfusion inside the brain are confusion, lethargy, memory loss. All of those effects will come in. So let's look at it. In the brain, increased sympathetic nervous system tone will come in so that it can vasoconstrict, so that it can supply the blood to the brain, even as little as blood, as the little amount of blood as it is, it should get there. On the other hand, kidneys increase renin-angiotensin system. They're going to have the same effect as sympathetic nervous system. And at heart, it's going to decrease the cardiac output. CO means cardiac output. Because why is cardiac output decreasing? Cardiac output is decreasing because heart is not working properly. Heart is not functioning as a pump. When it's not functioning as a pump, it's not pushing the blood out. It's not pushing enough blood out. It's not working as a pump, so it won't be able to push all the blood out. When it's not working enough, so the cardiac output will go down. On the other hand, now vasoconstriction happened at arterial level. This was the effect. At arterial level, we had arteries affected, we had pulse wave velocities affected, stiffness went up, elasticity gone down, afterload increased, heart had to push a lot, left ventricle had to work a lot to put the blood into the vessels, increased myocardial oxygen demand came in. When increased myocardial oxygen demand came in, organs went into ischemia, and every organ reacted in a different way. Brain went on, increased its sympathetic nervous system tone. Kidneys went on and increased its renin-angiotensin system. And heart has gone down. If heart is affected and decreased cardiac output, none of these will be able to do a thing about it. Because if heart cells are dead, you cannot regenerate them. They're just going to develop a scar there. Now, this was the arterial level. Now, what will happen if acute inflammation, sympathetic nervous system, and hormonal effects, all of them came along for the venous constriction, for the vasoconstriction of the venules and venous? Fluid redistribution will happen, increased preload, increased pulse pressure and alveolar edema, and decreased oxygen content blood. Now let's explain this phenomena. Now, if venous constriction is happening, if venous system, if veins are affected, they're constricted, what will happen? It will push the blood out. It will push, if veins basically are dilated, veins are there to pool the blood. Veins are not constricted. Veins don't have any kind of muscles there to constrict or dilate. They're stiff structures. They don't have anything to do with the blood pressures. But when the constriction happens, what's going to happen? Fluid redistribution will happen. Now, all the fluid that was pooling inside of those vessels, when they're contracted, when venous contraction happened, the blood is going to go up. At that level, contraction happened, fluid is going to go up. Same mechanism will follow through, and this will lead to increased preload. We talked about afterload. What was afterload? Afterload was the amount of force, amount of pressure left ventricle has to to push the blood out of it. Now, what's preload? Preload is accumulation of blood. Preload is actually pressure of the veins. Preload is actually pressure of the veins, because all of the veins from all the body is coming in and emptying in the right atrium. So if we have to understand, if we have to learn what a preload is, what the preload of this specific heart is, we go on and check the pressure of left or right atrium, because right atrium gives a perfect indication of what preload is or what venous pressure right now is. Because we cannot check the pressure of the veins. What we can do is check the pressure of the right atrium. So increased preload will be happening. More and more blood is coming in, more and more blood is pooling in the right atrium, and the preload is increasing. Next on, the pulse pressure and alveolar edema will come in. Now this is a very important phenomena. Why alveolar edema is coming in? Why pulse pressure is increasing? When preload is increasing, what will happen to the right ventricle? Right atrium has a lot of blood now. It has a lot of blood. It will go into right ventricle. Now, right ventricle has a lot of blood to push into the pulmonary circulation. Now, more and more blood will go into pulmonary circulation. Now, what's the function of pulmonary circulation? That pulmonary artery will take the blood into the lungs to get this amount of blood oxygenated. When it was up to certain amount, the lungs were able to oxygenate the blood thoroughly. Now the amount of blood that's coming their way to the lungs, it has surpassed the normal amount. When it has surpassed the normal amount, there will be pooling of blood inside the pulmonary vasculature. There will be lines and lines of blood. You can imagine this in your mind, that there are lines and lines of people. Just like that, there's whole pooling of blood coming in. Whole amount of blood which is coming out of right ventricle is going to pool inside the pulmonary vasculature in order to get oxygenated and then to move on to left atrium. They cannot go to left atrium without being oxygenated. So they're going to pool in. When they pool in, what will happen? Fluid will leak into the alveoli and it will cause alveolar edema. At the same time, pulse pressure will go up. Because of all of this phenomena, pulse pressure will go up. But this blood cannot stay in the lungs. This blood cannot stay in the pulmonary vasculature forever. It has to move on. So most of the blood does not even take enough oxygen with it. It just moves on because they have to move on. They didn't get enough oxygen. So that's why oxygen content of the blood goes down. Because the blood did not have enough time to get oxygenated inside the pulmonary vasculature. Because there was a lot of blood, maybe all of the blood which was there got a little oxygen, but none of it got enough oxygen. So oxygen content of the blood goes down. So that's how systemic hypertensive heart disease affects the venous level. Now, increased afterload, there's a connection between these two. Increased afterload, the amount of force, amount of pressure left ventricle has to exert to push the blood out of left ventricle is going to affect pulse pressure too and alveolar edema too. How is that happening? Increased afterload means increased pressure, increased pulse pressure. But what is alveolar edema's connection? Alveolar edema is affected because when left ventricle has enough blood coming its way and it needs more time and more vigorous pressure to put the blood out, what's going to happen? The blood is going to pool inside the left atrium because now left ventricle is working at its maximum, but it's not working efficiently. Now left ventricle is there, but left atrium is going to pool the blood in. When left atrium is going to pool the blood in, what will happen? That pulmonary vein which came in and emptied inside this is going to pool the blood, and one way or another it will lead to pulmonary vasculature and blood will start pooling in there, and that will lead to alveolar edema because the fluid will leak in. So in the first lecture about cardiovascular system, I told you left ventricular failure or any pathology with the left ventricle is going to affect the pulmonary vasculature, and in turn afterwards for a long time, if it goes for a long time, it's going to affect the right ventricle, the right atrium. Even just a little left ventricular failure will lead to the whole cardiac failure after a little time, because it will in turn affect the other structures in pulmonary vasculature, then right ventricle, then right atrium, because they're connected in a loop. Anything happens to any of them, all of them are going to get affected. Now, this decreased oxygen content of blood we talked about, because of this whole phenomena, decreased content will lead to end organ ischemia, just like this. But in arterial vasoconstriction, major organ that was going to get affected was heart, because increased myocardial oxygen demand was happening. None of the other organs were asking for more oxygen. They were asking for the normal amount of oxygen that's required by their cells and tissues to work properly. But the heart needed more and more oxygen. So that's why in this arterial overview, increased myocardial oxygen demand, the major organ that's going to get affected is cardiac cells, heart. But in the venous structures, when oxygen content of the blood goes down, which organs get affected? All of these. They have a bigger role in affecting these organs. And we all know brains are going to go and increase their sympathetic tone, kidneys are going to go increase their renin-angiotensin system, and heart is going to reduce its cardiac output. I hope you got the point of it. Now, the pathology of systemic hypertensive heart disease. Now, this is what it looks like. You can see it. Now, this is a normal structure of the heart, and this is abnormal structure of the heart. How can we say it's normal and how can we say it's abnormal? How can we say it's physiological? How can we say it's pathological? It's physiological because they are spaced at regular intervals. These nuclei are spaced at regular intervals. These cells, these fibers are at regular intervals. And look at it now. Now they are hypertrophied, they are widely spaced, and these muscles are elongated now. Now that's what a hypertensive heart will look like, because they have been stretched. Look at it, it's lax. Stretched at some places where it's required and lax at some places where it's required. Now look at this. These are stretched, nuclei are elongated, nuclei are in bigger size, they are stretched along the way. That's how I know that it's pathological. It's after hypertensive heart disease. What are going to be the clinical features of a patient presenting to us with systemic hypertensive heart disease? You can just guess them. First of all, chest pain, angina. When does angina happens? We talked about angina in detail in the last lecture. So, what chest pain is? What angina is actually? Angina is crushing chest pain at substernal point, at substernal space. It runs up to the jaw. It goes up to the left arm till the end even. So if a patient is suffering from hypertension, it's going to get angina. What kind of angina it is, still not sure. It can be unstable angina, it can be stable angina, it can be angina pectoris. We talked about all the types of angina and angina pectoris in myocardial infarction lecture. You can go there for reference. Next on, we have tightness or pressure in the chest. Patient will feel like this whole chest has been grabbed by something, like some kind of pressure is being put on their heart. Because of a lot of pressure which is being generated, to overcome that, patient will feel tightness or pressure in the chest. Patient will be short of breath because patient will want to inhale more and more oxygen. More and more oxygen, patient will be short of breath because in some cases, oxygen demand or oxygen content of the blood has gone down. End organ ischemia is happening in some cases, so patient will be short of breath. Patient will be fatigued because not all the body cells, not all the body parts are getting enough supply. They're not getting enough supply. Their cells are not being supplied by enough oxygen or nutrients or anything like that. So they are fatigued, their muscles are fatigued, their energy reservoirs are depleted, they are not up to their maximum capacity to do any kind of work. Now, systemic hypertensive heart disease has the following effects. Now let's get on to the effects. We learned about the pathology, we learned about the pathogenesis, we learned about which factors are contributing in developing the systemic hypertensive disease. So what are going to be the effects of it? Patients of systemic hypertensive heart disease are going to have these effects. They enjoy normal longevity and die of unrelated cause. They live normally, they take medication, they live normally, they don't have any life affecting effects. They don't have any effects like diabetes patient which are going through amputations, which are going through a lot of other stuff, which are going through end organ damages. They can go through end organ damages, these patients, but if they keep the blood pressure in control, there's no problem with end organ ischemia or any kind of amputation. So they enjoy normal longevity and die of unrelated causes. Not because of this. You can say that that patient was suffering from hypertension but died of something other than hypertensive diseases. Next on, they develop ischemic heart diseases owing to the effects of hypertension in potentiating coronary atherosclerosis. So a hypertensive disease can lead to ischemic heart disease. There's a whole lecture about ischemic heart disease. You can go back and get some background from that lecture. But developed systemic hypertensive disease can lead to the development of ischemic heart disease, can lead to the development of atherosclerosis, because when there's high blood pressure, sometimes it ruptures the vessel. Sometimes it ruptures the vessels, all the inflammatory mediators will come in, all the fat cells and everything, and they will lead to the formation of atherosclerosis. We talked about how the atherosclerotic plaque is formed. So increased blood pressure, increased pressure inside those vessels due to systemic hypertensive heart disease will lead to the development of atherosclerosis, which is basically coronary atherosclerosis, and the vessels will look like this. The lumen is shortened, and this will in turn lead to ischemic heart disease, and now that can be life-threatening. Now we cannot say that patient die of blood pressure, but it was the consequence of it. Next on, we know that they suffer renal damage or cerebrovascular stroke. We just talked about it. We just talked about which organs suffer the end organ ischemia. We talked about kidneys and brain are major organs to suffer end organ ischemia. So if kidneys are being affected, they suffer renal damage, or so how they are suffering renal damage, they're going to hyperperfusion, and if it's sustained for a long time, they're going to kidney failure. And cerebrovascular stroke. How cerebrovascular stroke is coming in? If any kind of thrombotic plaque or any kind of emboli or any kind of atherosclerotic plaque is formed inside the brain vessels, inside the vessels that supply the brain with blood supply and the major vessels, and if they're compromised, that whole area of the brain will go into necrosis and patient will suffer through cerebrovascular stroke. Or if it goes into hypoperfusion, if the blood supply has gone down, if the blood supply has gone down because the cardiac output has gone down, what are going to be the consequences? The consequences will be cerebrovascular stroke, because still that area of the brain is not getting enough oxygen, not getting enough blood for its sustainment. So that area will go into necrosis. Next one, experience congestive cardiac failure. We learned about how an angina pectoris or an ischemic heart disease leads to congestive cardiac failure. It's an ischemic heart disease lecture, but let me revise it for you. First of all, patient gets pain inside the chest, a crushing pain inside the chest. That's angina. Now, angina pectoris specifically happens when 75% of the lumen, a booming 75% of the lumen has been compromised. When it's been compromised, what will happen afterwards? If the 75% is already compromised, more and more blood will want to go through, but less and less blood can go through. And if a person is training, if a person is exercising, the demand of oxygen goes up inside the heart. Now, the lumen is so short that it won't be able to comprehend. It won't be able to compensate. So the patient will feel crushing pain inside the chest. Now, that will, if it happens for more than 15 minutes or it happen in bouts, it will lead to necrosis of those cells. Those cells will die, and that's called myocardial ischemia. Now, that myocardial ischemia will lead to congestive cardiac failure. If it's gone up, it will one day or another lead to congestive cardiac failure. So these are the effects. They can enjoy the whole longevity, but they develop ischemic heart diseases because of hypertension. They develop atherosclerotic plaques. Next on, it can suffer the renal areas. It can suffer the cerebrovascular stroke, and we can also experience congenital heart failure. But before we go on to the next slide, let me tell you that this renal damage and cerebrovascular stroke can also occur because of increased blood pressure, increased blood supply. We'll get into the details of that, but you have to keep that in mind too. Next on, we have cor pulmonale. What is cor pulmonale? You must have heard this line so many times, cor pulmonale. It's actually pulmonary hypertensive heart disease. It's basically failure of pulmonary vasculature, which in turn lead to heart disease, hypertensive heart disease. So pulmonary hypertensive heart disease is called cor pulmonale. This is a normal heart. Now this is a right ventricular hypertrophy. Now, why right ventricular hypertrophy is happening here? Because the pulmonary vasculature is being affected here. When the pulmonary vasculature gets affected, pooling of blood occurs in pulmonary vasculature. So now, just like the systemic hypertension was happening and more pressure was being exerted on the left ventricle to push the blood out, now same amount of pressure is being exerted on the right ventricle to push the blood into the pulmonary circulation. And if there's more and more resistance there, right ventricle will push the blood with more and more pressure. And remember that right ventricle is not used to getting more and more blood pressure, not used to pushing the blood with that much pressure. And their walls are thin, and they're not supposed to push the blood at that pressure. But what happens? The walls thicken up. Now the walls thicken up because they have to push the blood out of their chamber in a very high pressure. So walls thicken up, their size goes down. Now the size has gone down. You can see this is the right ventricle. Now the muscles came in, the size went down. This is how it will go to pulmonary vasculature. Next on, we have pulmonary hypertensive heart disease, or called pulmonale etiologies. What are going to be the causes of development of pulmonary heart disease? First of all, COPD. Next, pulmonary embolism. Next, pulmonary fibrosis. Next, sleep apnea. Next, myasthenia gravis. Now let me get to the point. Before we move on, let me make you understand why all of these conditions are leading to pulmonary hypertensive heart disease. First of all, COPD. What happens in COPD? It's chronic condition of respiratory system in which all of those alveoli are destroyed and there's a lot of fuss going on inside the respiratory system. So what will happen? More and more area of the lungs is not contributing in oxygen demand of the blood supply, is not contributing in supplying the blood with oxygen. So more and more pooling of blood is happening there. When more and more blood is pooling, what will happen? It will lead to pulmonary edema, and it will lead to pulmonary hypertension, pulmonary embolism. If there's any kind of emboli present in pulmonary vasculature, it can be anywhere. It can be in pulmonary artery, it can be in pulmonary vein, it can be inside the vasculature. For example, it's in pulmonary artery and it's at the level of this, for example, before even getting to the lungs. If there's an emboli, now the right ventricle has to push the blood out of it at so higher pressure to compensate this emboli. Now this emboli, if this is the vessel and this is the emboli blocking blocking the lumen, now only this space is present for blood to go on. Now which blood will go on? If we are pushing the blood at normal pressure, the blood will start pooling in here and little blood will go in. Now the right ventricle has to push the blood at such a higher pressure that at least one streak of blood or one part of blood goes just through at very high pressure. And yes, the remaining blood will go back, will pool in. And that's actually leading to pulmonary hypertension. That's actually leading to right ventricular hypertrophy. But never mind, so it needs more and more pressure. And that will lead to pulmonary hypertensive heart disease, or called pulmonale. Next on, pulmonary fibrosis. If fibrosis is going on inside the pulmonary vasculature, the same effects. The heart needs more and more pushing. The right ventricle will push more and more blood inside the pulmonary vasculature for it to get oxygenated, but it's not getting oxygenated. The amount of oxygen is going down because pulmonary areas is going into fibrosis. More and most of the areas are not even contributing. So this will lead to pulmonary hypertension. Next on, sleep apnea. Sleep apnea, you must have heard the name but never the whole detail. What happens in sleep apnea? Sleep apnea, when a person sleeps, after some time, when the person goes into deep sleep, person stops taking the air in. These are episodes. These are called episodes of apnea in which patient is not breathing. Patient must be trying to breathe, but patient is unable to breathe. It can be central. Sleep apnea can be central sleep apnea. Sleep apnea can be obstructive sleep apnea. Central sleep apnea means there's something wrong with the brain. There's something wrong with the respiratory center. On the other hand, in the sleep apnea, if the person is don't have a central problem, they have obstructive problems. They have thick necks. When they sleep, the epiglottis goes down. These structures just congested and the air is unable to go in or come out. And that patient will be... So these bouts will be happening in sleep apnea. And it will be more than 10 seconds. It will be more than 15 seconds. In some cases, in clinical practice, I've seen it lasts for more than 40 seconds. And when the patient is about to die, when the patient is not getting enough oxygen and patient is not breathing, it's about to die, brain hits it with a message to wake up. So the person goes like, and that's how this whole process works in sleep apnea. Now, let's get to this pulmonary hypertensive heart disease, how sleep apnea is connected to pulmonary hypertensive heart disease. Sleep apnea will lead to bouts and bouts, or 30 seconds, 40 seconds periods in which there's no breathing whatsoever. Now the blood is coming into pulmonary vasculature to get oxygenated, but there's no oxygen. Patient is not even breathing for oxygen to get in and get oxygenated. If the patient is not even breathing, how this blood is going to get oxygenated? So blood will pool in. Blood will be like, I have to get some oxygen, then leave. When the blood is pooling in, what's happening in the right ventricle? Right ventricle is getting the same blood and pushing out, but now right ventricle sees there's a lot of blood already there. How can I push more blood? How can I make this circulation go? How can I stop this circulation? If I don't do something about it, this circulation will be stopped, this blood will pool in, and there will be nothing coming back to back to left atrium, back to left ventricle. And what will left ventricle provide the body with? Nothing. And the patient will die. If the coronary vessels don't work and supply the lungs with the blood supply, patient will die eventually. So right ventricle pushes with enormous pressure so that this circulation must move on. It should not just halt. And that's how this also leads to pulmonary hypertensive heart disease. Next now we have myasthenia gravis. Myasthenia gravis is a disease of muscles. It's a neurological disease. So this also has a role in getting to pulmonary hypertensive heart disease because it affects the muscles in that way that one way or another it leads to pulmonary hypertension. Next now we have poliomyelitis. It's the same mechanism. In poliomyelitis, muscles are gone due to polioviruses. They don't have any kind of effect. Person doesn't walk, person can't do anything. So the return is compromised and all of those pathologies will go on inside the body and that will lead to pulmonary hypertension. So all of it will lead to pulmonary hypertension and this is called cor pulmonale. Now, cor pulmonale means right ventricular hypertrophy because of pulmonary hypertension. You get my point? I hope you get my point. So this is actually the heart disease which is happening because of pulmonary hypertension. Next down we have cor pulmonales. Disorder predisposition to cor pulmonale. Which are the disorders which predispose to getting cor pulmonale? First of all, diseases of the pulmonary parenchyma. It can be because of diseases of pulmonary parenchyma, because of diseases of any kind of diseases which affect the pulmonary parenchyma. It can be pneumonia, it can be any of those diseases. It can be chronic obstructive pulmonary disease. We just talked about how COPD affects it. Diffuse pulmonary interstitial fibrosis. We talked about how fibrosis affects the blood pressure, the pulmonary hypertension, and in turn leads to cor pulmonale. Pneumoconiosis. Pneumoconiosis is actually a disease in which the people who are mining, the people who are exposed to this kind of environment get this, and this substance is gathered inside your lungs and patient can't breathe, and this will lead to pulmonary hypertension and in turn leads to cor pulmonale. Next one we have cystic fibrosis, in which patient lungs are gone already. It's filled of this material. They're unable to even exchange the gases properly. They're unable to even breathe properly. So they won't be able to supply the blood with the oxygen that the blood requires. And this in turn will lead to pulmonary hypertension, and that in turn will lead to cor pulmonale. Bronchiectasis. Now this is also a condition of pulmonary parenchyma in which more and more substances are gathered inside the alveolar level and bronchial level, and this in turn will affect the amount of oxygen that gets past that barrier and leads to the blood and oxygenate the blood. When it's not happening, when there's a problem with that, blood vasculature will start pooling inside the pulmonary vasculature. the blood will start pooling inside the pulmonary vasculature, and that in turn will lead to pulmonary hypertension, and that pulmonary hypertension will lead to cor pulmonale, because it will lead to hypertrophy of the right ventricle, hypertrophy of the heart, in fact. Now, it can be because of diseases of pulmonary vessels. In which pulmonary vessels are we talking about? Recurrent pulmonary thromboembolism. Now, pulmonary artery, pulmonary veins, all of them can get thromboembolism. They can get a thrombus or an emboli or both. When they are blocking the vessel, right ventricle is pushing the blood with more and more pressure. Right ventricle is hypertrophying, and this in turn will lead to systemic pulmonary hypertension, and that in turn will lead to cor pulmonale. Primary pulmonary hypertension. Primary pulmonary hypertension, will know that pulmonary hypertension will lead to cor pulmonale. Extensive pulmonary arteritis. If there's a problem with the arteries, if there's a problem with the pulmonary arteries and it develops arteritis, arteritis is inflammation. Extensive pulmonary arteritis will lead to more and more pressure required by the right ventricle to put the blood out into the pulmonary circulation. So that will lead to cor pulmonale. Drugs, toxins, or radiation induced vascular obstruction. If there's obstruction inside the vessels, now the right ventricle needs to do what? Push the blood out of it with more and more pressure, which will lead to pulmonary hypertension, which will lead to cor pulmonale. I'm picking up every point and relating it to cor pulmonale so that you get my point, so that you develop a concept that how every one of them are leading to cor pulmonale. Extensive pulmonary tumor microembolism. For example, a patient develops tumor and part of that tumor is in the blood, is in the vasculature, or the tumor is outside and it's pushing the, for example, this is the vessel and it's pushing the vessel. It's compressing the vessel. Now less blood supply is going through. More and more pressure will be required from the right ventricle to put the blood into pulmonary vasculature, and it will contract and it will increase in size. It will be hypertrophied and it will lead to pulmonary hypertension, and that in turn will lead to cor pulmonale. Next, now we have disorders which are affecting chest movement. These include kyphoscoliosis, marked obesity, neuromuscular diseases. Now, kyphoscoliosis and neuromuscular diseases, both of them will lead to these muscles being affected. Now, if the respiratory muscles are not working, if the diaphragm is not working, what will happen? You cannot breathe enough. You cannot expire enough. If they're not inspiring and expiring, there's no oxygen whatsoever. The blood will start pooling in the right ventricle, will need more and more pressure for it to, for the blood to go through the pulmonary vasculature. So that will lead to pulmonary hypertension, and that in turn will lead to cor pulmonale. On the other hand, obesity. Obesity is something in which a person is so obese, there's so much fat deposition that it cannot even move its muscles properly. It cannot even move its respiratory muscles properly. And due to its obesity, multiple other factors are contributing to it, and that in turn will lead to cor pulmonale. Disorders inducing pulmonary arterial constriction. How a pulmonary artery is constricted? Metabolic acidosis. Metabolic acidosis will lead to pulmonary artery constriction. We'll learn about the metabolic acidosis and metabolic alkalosis in the next lectures. We'll know how these affects one way or another to pulmonary arteries and how they're constricted in response to it. Next one, hypoxemia. Any reason which will lead to hypoxemia will induce pulmonary arterial constriction. Hypoxemia means low oxygen content in blood. That in turn will lead to pulmonary arterial constriction. Next one, we have obstructive sleep apnea. We talked about sleep apnea in the last slide. We talked about how central sleep apnea is. We talked about how obstructive sleep apnea is. And the obstructive sleep apnea, we talked about there's an obstruction, there's thick neck or any kind of obstruction, and a patient is unable to breathe enough. Patient is unable to breathe for a 10-second, 20-second, 30-second, 40-second periods. It has been shown that patient can go on without breathing for even a minute in obstructive sleep apnea. And then the brain hits the person, the brain hits the respiratory system to wake up because it's about to die. So in obstructive sleep apnea, what's going to happen? Patient is not getting any air at all. So how the blood is supposed to get oxygen if there's no air at all? So blood will start pooling in. When the blood will start pooling in, constriction will happen. Arterial constriction will happen. That in turn will lead to pulmonary hypertension, and that in turn will lead to cor pulmonale. Idiopathic alveolar hypoventilation. Idiopathic means we don't know the reason of it. There's no cause of it. There's no pathology behind it. Alveolar hypoventilation. If alveolar level is hypoventilated because of idiopathic reasons, if it's hyperventilated, it's not having enough oxygen. If it's not having enough oxygen, blood is not getting enough oxygen. The blood will start to pool in. Right ventricle will have to push more blood with more pressure, and that in turn will lead to increase in its size, hypertrophy, that pulmonary hypertension, and then cor pulmonale. I hope this extensive slide will get to you that how this whole system, that how this whole CV system and pulmonary system was connected, and how any pathology in any one of them leads to the pathology in the other system. Next on, we have pulmonary hypertensive heart disease pathogenesis. So the lung diseases affect. Lung diseases lead to inflammation, lung diseases lead to hypoxia, lung diseases lead to fibrosis, lung diseases that lead to parenchymal loss. All of these affect and increase the arterial stiffness, vascular remodeling, and endothelial dysfunction. This will lead to pulmonary hypertension. We have studied thoroughly how all of these factors are affecting and leading to pulmonary hypertension. But still, I'll give you a hint, a small detail on it, that all those lung diseases which cause the inflammation. When inflammation is there, when lungs are inflamed, alveoli are inflamed, the oxygen cannot pass through, the oxygen cannot go through. When the oxygen cannot go through, it cannot be saturated with the oxygen, the blood cannot be saturated with oxygen. If there's any hypoxia, when there's not enough oxygen there, blood is not going to be saturated with oxygen. When there's fibrosis and lung structures are affected, the major part of the lung is not contributing in providing the blood with oxygen. So major part of the blood is not getting enough oxygen. When there's parenchymal loss, major part of the blood is not getting enough oxygen. Now all of these four factors which are happening because of a lung disease are going to affect the vasculature, the pulmonary vasculature. So arterial stiffness will go up, vascular remodeling will happen, and endothelial dysfunction will happen, and all of this will lead to pulmonary hypertension, and this pulmonary hypertension will lead to right ventricular hypertrophy, and that right ventricular hypertrophy will lead to right ventricular failure, and that's right ventricular hypertrophy, afterwards we call it cor pulmonale, and this in turn will lead to right ventricular failure. So all of this hypertrophy and right ventricular failure, along with it, we call it cor pulmonale. So this is the pathogenesis of it. So in cor pulmonale, what we're going to have, what are the symptoms that we're going to have? Fatigability, patient will be fatigued. Why patient is fatigued? Patient is fatigued because patient is not getting enough oxygen whatsoever. Patient is fatigued. Patient will have dyspnea on exertion because already all the systems are not getting enough oxygen. And when we exaggerate, when we go for an exercise, patient will have dyspnea. Patient will need more and more oxygen to perform such actions. And if it's not getting enough oxygen, patient will be dyspneic. Patient will be hungry for air. Syncope. Patient will have syncope. Syncope is an attack in which patient, it's a medical emergency in which patient will need medical emergency services to get back to normal, because cor pulmonale may lead to syncope in which patient is even unable to breathe. Patient goes into syncope. You can learn about syncope in detail. You can watch a whole video on YouTube or something like that. It's very helpful, and it can happen in any society, anywhere. You won't even know that this patient is going to develop syncope. Next on, the patient will have chest pain. We all know why chest pain is happening, because cardiac structures are being remodeled, vasculature is being remodeled, enough oxygen is not there, the heart is not getting enough oxygen, end organ ischemia is happening. Patient will feel chest pain because the cells of the heart are dying or even about to die, or not getting enough oxygen or working at their maximum capacity. Patients will develop palpitations. Palpitations are most closely associated with chest pain. When the patient has chest pain, it's going to develop palpitations afterwards. Patient will feel like this whole palpitation is going on, and they will feel like they're going to have a heart attack, but it's just palpitations, and these just go away. In most cases, palpitations just go away. Next one, we have abdominal edema or distension. Why abdominal edema and distension is happening? Because if right ventricle is hypertrophied, if right atrium is hypertrophied, what's going to happen? All those veins which are going to get emptied inside these vessels, inside these circles, inside these atrium and ventricles, are going to pull the blood in. When the blood is pulled in edema, when the blood is pulled in abdomen and the legs, the fluid will escape through those vessels and cause edema and distension. Lower extremity edema, just like this process, the blood will pool in inside those vessels, escape the vessels, and get into the interstitium and cause edema inside those areas. Now, this is what it looks like on a gross structure. This is what a cor pulmonale looks like. You can see the major difference happening in both of these. This is how we differentiate between normal and abnormal. So, what's pulmonary hypertensive heart disease? Acute. Let's talk about acute and chronic. What if it was not because of any COPD or any kind of disease that was patient was having for a long time? Maybe it happened overnight. What can be those conditions which can lead to pulmonary hypertensive heart disease overnight? It can be because of a thrombus, it can be because of an emboli, it can be because of any obstruction. Patient was fine, and suddenly an emboli came in, a thrombus came in, attached to the surface, blocked the entry, blocked the lumen. Now the blood pressure required for right ventricle to push the blood into pulmonary vasculature has gone up, and that's called acute pulmonary hypertensive heart disease. You can see this led to this level because of a microthrombi. This will in turn cause hypoxemia, hypercapnia. Hypoxemia means low oxygen content. Hypercapnia means more carbon dioxide content. And this will lead to edema because more and more fluid will be leaking through, and over distension of some cells, and loss of lung volume. Loss of lung volume will be seen because that area or that vessel is not supplying it anymore, and this area of the lung has lost because it's not getting enough blood supply. It's a basic loss of lung volume because of this microthrombi that has occurred, and major chunk of the lungs are gone. Major chunk of the lung surface is gone, or the cells are gone. You can see the alveolus. Now, functional residual capacity has increased, functional residual capacity has decreased. You can see the fluid moving in, the alveoli are filled up to the half level. So how are they to provide the blood with the oxygen? So that's how hypoxemia will come in, and hypercapnia will be there because more and more carbon dioxide will be contained inside those cells. Now, what's chronic pulmonary hypertensive heart disease? Chronic pulmonary hypertensive heart disease, we all know about chronic pulmonary hypertensive heart disease. It's because of those diseases which are chronic in nature, like COPD, like other diseases, in which what happens? Extreme right axis deviation happens, and this is how the AVF looks like. On ECG, when you look at the AVF, this is how it will look like. On AVF slide, this is how it will be shown. You'll know that patient is going to have extreme right axis deviation. So what is pulmonary hypertensive heart disease chronic? When those diseases like COPD or fibrosis, they came into play, they affected the lung volumes. Now when the lung volumes are affected, the blood coming in is not getting enough oxygenated, the blood is pooling in, when the blood is pooling in, right ventricle needs more and more pressure, and more pressure will be generated inside the right ventricle, and that will lead to right axis deviation in some kind. And how do we find it on a slide on an ECG? This is how we find it. It's extreme right axis deviation. When we check for it, it will be extreme right axis deviation on AVF. So this is all about it. So what we learned in this lecture is that how very minute factors lead to pulmonary hypertension, lead to systemic hypertension. We learned about how systemic hypertension and pulmonary hypertension are differentiated from each other. What are the causes and factors of systemic hypertension? What is the pathogenesis of systemic hypertension? And compared to it, how pulmonary hypertension affects it, how pulmonary hypertension is developed, what's the pathogenesis of pulmonary hypertension, and how it's treated or how it's managed. For today, that's all about it. If you want to get more review on it, you can go back to ischemic heart disease lecture. You'll learn more about this cardiac failure slides and how an angina leads to heart failure on those slides. Keep watching sqadia.com. Thank you very much.